Thank you very much indeed for the kind introduction. I don't know whether I'm the international component of today, but no, we are still part of the United Kingdom and absolutely proud to be so. What I want to do is, first of all, tell you never work with the comms department who suggest you need to personalise your slides and put a photograph of yourself in the top corner. What you're looking at is the effect of 10 years trying to persuade people to adopt technology, and I think we'll move on very, very quickly, and please don't tell anybody about that. A little bit about Scotland, first of all. We've got a population of 5.3 million, which is really fortunate because that's a good size where you can scale up and do things with. We're in a very fortunate position. We believe that we've got health and social care devolved to the Scottish Parliament. And coming from a kind of benign Stalinist society, we have gone down a slightly different road to colleagues in England and Wales. And we're relatively close to what's been happening in Northern Ireland. But we've got a budget for healthcare of about 12.4, almost, it's still rising, almost 13 million pounds, and a formal social care budget of about 2 million. Our health service is divided into territorial health boards, and you can see the split of their budget. And there are these things called special health boards, which cover the whole of Scotland, and my organisation, NHS 24, is one of those. Now, we started off very similar to what was lovingly known in England as NHS Direct. We answered the telephone when GPs are closed, but we have evolved as an organisation, and we're now the national provider of telehealth and telecare services across Scotland, promoting the use of digital technologies whenever it is safe, effective, and probably the most appropriate word is that word, when it is appropriate to do so. Just because you can do something with technology doesn't mean you should. Now, clearly, we have enshrined in legislation the integration of health and social care, and we have formed these organisations called integrated joint boards, and they have got an integrated budget to deliver health and social care. And that budget was built from community health and social care services. But what is interesting, it also involved a significant proportion of our acute hospital sector budgets. Because what we learned in the past from previous health service reforms, which were primarily done in the days of things like GP fund holding, is that if hospitals didn't have any skin in the game, in other words, if there was no financial risk or benefit to the hospitals, they would continue to do their own thing. But we've got a reasonable amount of the acute hospital sector in the budget, which means that they are actively involved and interested in transformational change and redesign. So what are the drivers for change? They're the same in Scotland as they are in England. Our focus is on quality. Our focus is on person-centredness. Our focus is on believing that innovation is the only way we can deliver sustainable health and care services for the future. But it's not all motherhood and apple pie. We've got significant challenges with inequalities, the differences between the have and the have-nots. Scotland remains the sick man of Europe, and although we are living longer, the issue for me is not how long we stay on the planet. It's all about healthy life years. And it's not simply about keeping people out of hospital. Being a prisoner behind your own door, dependent, lonely, and isolated, is equally bad. And there are significant examples across the whole of the United Kingdom where that is the case. But what we realised is that it had been possible to integrate budgets between health and social care for over 10 to 15 years in Scotland, yet no one did it. There was no barrier. And the only way we believed we could make a transformational change in this area was to legislate, and that is what Scotland did. But actually, as Paul was saying, it's what grabs the headlines. It's not about community services. It's not about the integration of health and social care. It's all about hospitals. And this has to change. And this is one of the most modern hospitals in Europe. This is the Queen Elizabeth II Hospital in Glasgow. It's euphemistically known to the local population in Glasgow as the Death Star. Quite a good name. Actually, it's called the Death Star because it looks a little bit about the spaceship in Star Wars. But clearly hospitals are very dangerous places, so maybe the name is equally apt. But the reality is that is the battlefield for us all. I mean, that is a rural village down the Clyde in the west of Scotland. But it's where people live. People spend most of their lives in their communities. These communities used to be rich and vibrant. People used to want to live there. People wanted to work there. But now the ability for us to recruit and retain skilled health and care professionals in these types of environments is becoming increasingly difficult. And people are making life choices. Families with young children are moving away from these communities because they want to source the best education for their children, so they move to more populated areas with better schools. And the elderly are often making choices to move away from these communities before they believe they're going to become frail and dependent because there's no access or no easy access to services. So how do we sustain our communities? Because we can talk about technology, we can talk about health and care, we can talk about the issues of our organisations and us as health and care professionals and managers and industry leaders, but it's all about people. It's all about informal carers, and we will all be caregivers at some point in our lives. And it's not about replacing that bond, that responsibility with technology. It is a how, with the appropriate use of technologies, we can make life easier, not simply for the service user or the patient, but for the carer and those round about. So it's never about the technology, it is all about innovative service redesign. Now that is the vision for the NHS in Scotland, and our government has recognised that we will not achieve that by 2020. No one can disagree with anything on that slide. I'm not going to read it out to you, because it's the same vision of all health and care systems across Europe. Slightly different words and slightly different orders, but the intention is the same everywhere. And we've recognised we're not going to make it because we haven't transformed fast enough, and there is now an absolute requirement for us to accelerate and move forward, and we believe integration is the key to do that. So that is the legislation that was brought before the Parliament and is now enshrined in law, and it is now part of law in Scotland that health and social care should be integrated. But we looked internationally to see what the evidence told us about integration, and what it basically said is this: plan for populations, not for delivery structures, and not what is best for organisations. Pool resources, that's not simply money, it's also about people. It's about working smarter together and promoting understanding. It's embedding GPs, social carers, clinicians, and everyone who is interested and has interest in this agenda in the process of service planning. And it's really all about strong local leadership and local planning. And that, for us, was what it was a tool for. It's about promoting the understanding of what is real, what is immediate, and most importantly, what is important to our citizens. And at the end of the day, if it is not person-centred, we won't be taking things forward, and they won't be funded in Scotland. So the bill was a principle for the integration of health and social care. It had nationally agreed outcomes, not outputs, for health and well-being. It talked about integrating the governance arrangements, and that's been a challenge in some areas. Integrating budgets has equally been a challenge and continues to be so. But there is an accountable officer who is accountable for that shared budget. And for us, it is the focus on strategic and, most importantly, locality planning. And that is really still getting off the ground. But the liberating thing for us is this: it's about an outcomes-based approach. It's shifting that focus from activities to results, but to results that matter to real people. Not what the doctor thinks is best or the social worker feels is the right thing to do, but what is best for the individual service user and their carers. It's about connecting all those pieces of the jigsaw and putting them together. But the injection of reality is, have we cracked it? No, we haven't. We're on a journey, and we're not at the finish line. Every developed healthcare system around the world is looking at integrating. They're all at different stages. And we need to collaborate together to move this whole agenda forward. So one of the ways we're looking to speed up the implementation is using disruptive technologies and putting that at the heart of everything we do to try to improve the coordination of care delivery across these established boundaries. And we have had an international funded project called Smart Care, which has been looking at falls prevention, which is a challenge everywhere we go. And these were the regions across Scotland that were part of this project. And they stretch from, in the north, Glasgow and some of the most deprived areas in Glasgow, down into remote and rural areas. And we've even got a very troublesome American citizen who lives down in South Ayrshire with a golf course, who is part of the delivery network, but enough about him. But that's what the project was all about doing, and it appears very simple. It was focused at the over 50s. It was focused in a clear geographical area. It was looking at falls prevention and management, and it was looking about using ICT. Not too difficult there then. But when you look to see what conventional services that were out there, there were lots of them. And these are examples. And the vast majority of these services were known to the vast majority of people, but not all services and not to everyone. And you found out that some people only knew about services because they accidentally bumped into them and would use them because they found out that they worked. But it wasn't coordinated in any which way. The other thing that Smart Care did was, and this was one of the fascinating bits for the industry people in the audience, is that service users became part of the procurement process. And you should have seen the face of one of two of the companies that came along to present to the service users. And they were certainly a harder and more thorough audience in giving scrutiny than some of the senior health and social care managers. But that was very important in this project because it was really about true co-production. So this is what Smart Care was. It was an online person-centred service there to support people. It was all about promoting enablement, self-care, information sharing, and it was about benefiting people in a way that helped them manage their long-term conditions who wanted to remain at home. But it was also about supporting, as I said earlier, those important people, families and carers. And these were the components, and it was about integrating what was already there. There was a falls assistant, so people could assess for themselves their risk of falling. It was about a person-held file, where information held by either the local authority or the local health system could be stored and accessed by the person and their family with permissions. There was a calendar and a diary, and it connected people to services in their local communities, integrating those services both in planning and delivery. So, what did it do? It linked with this other process we've got, which is called living it up. This is about empowering people to take more responsibility for themselves, and it's about engaging people with services that are already there in their local communities, not about new services. The Person's Health file was transformational. It allowed the single shared assessment that was carried out either by a healthcare worker or a social care worker to be automatically uploaded from the local authority system into the person's own file. And the person could access it, they could read it, and they could feedback if there were issues wrong. In the first 32 of these very important documents that were downloaded, in 100% of cases, there was one significant error in each and every one of those files, picked up by the patient. Now, the patient didn't criticize the health or care provider. That's really important. They actually were grateful to see it and that they could make the changes. We also uploaded from the health service our emergency care summary, so all patients had access to the full list of drugs they were prescribed, their allergies, and so on and so forth. And that was freely available to them all. And to get our clinicians to agree to that happening was a major problem, but it's now in place. The social work departments in the areas allowed direct access to their care coordination software systems. So people could see when the carers were coming to visit and also the name of the person that was coming. And that was really important for some of the reasons that we've heard earlier. It's not possible to have a group of 2 carers who always come to look after the same person. So knowing that it's a different carer that's coming at 11 o'clock that morning and knowing what their name is before the doorbell rings gives that sense of security, comfort and control to the person, which was very important. So smart care was disruptive, but you know what? It was nothing other than you would want for yourself or for your own. And it was flexible. It allowed you to do things conveniently when you were independent. It allowed you to do more as you went through states of dependency. But it recognized that you also got better as well as sometimes deteriorate. And that flexibility, which was fundamentally important. I'm not going to talk through this slide, but all I'm going to say to you is that it is probably one of the most promiscuous IT systems I've ever seen, and it allows anything to plug into it, and it plugs in to almost anything. So it would log in, you could plug into any of our databases within the health and care system. It could plug into most of the health and social care management systems, GP systems, and so on and so forth, if it was given permission to do so. And this whole thing about data flow and data transfer is what's going to make integration possible. So, we had more effective sharing of information, better coordination of care, more effective use of technologies. It made health and social care people talk together because they had to work out how they were going to use the technology. It increased self-management, earlier identification of falls, but most importantly, it gave people confidence. And it has delivered for us some sustainable solutions. So it's all about choice. It's all about giving control back to the person. It's about connecting people together with their communities. It's about collaborations across health and social care between formal sector, the third sector, to the individual and their families. And whatever else I talk about, the key for us in the future are communities. Communities of care, either virtual or geographical. So what does that mean for us? Is it sorted? No, it's not. But what we need to do is we need to keep things simple. We need to collaborate together because we're not going to be able to do it on our own. But don't wait till you've dotted all the I's and crossed all the T's before you start in this journey. Whatever else we do, we need to go back to our day jobs and we need to take this agenda forward and encourage people to move and to move now. We owe it to ourselves, we owe it to our children, we owe it to society as a whole. Thank you very much indeed.